Great. Well, thank you all very much for joining us at this quarter's edition of the Quarterly Journal Club. As you know, this is the topic is failed rotator cuff and sort of management of the massive irreparable tear. We are honored to have some true thought leaders and innovators in this arena. Doctors Grant Garrigou, Surena Namdari, and Basmel San to sort of hopefully provide insight and maybe some banter on this relatively controversial topic. So without further ado, thank you very much. Thank you for Smith Nephew for sponsoring us. And I think we have a quick message from them before we get going.
At Smith & Nephew, we strive to put solutions in your hands that can allow your patients to live a life unlimited, and the shoulder space is no different. Here at Smith & Nephew, our focus is on providing you options throughout your patient's continuum of care with cutting-edge products like Regenerative, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the new ATOS shoulder system starring the ATOS Metastem that allows for maximized stability and an elevated surgical experience with an efficient system to help simplify shoulder surgery. We are honored to support the ASDS Foundation, and it is our mission to continue to provide you with the most innovative solutions in the shoulder to help restore the patient's ability to live their life unlimited.
Awesome. Chris, anything you want to add?
Yeah, echo what Eric had to say. This is supposed to be really interactive. So we've got these awesome thought leaders that we could ask great questions from the audience. So either send me a chat if you want me to ask something anonymously, or send them through the group and we'll interrupt to make sure we get your questions across. So thank you for joining us, everyone.
Awesome. Thank you all. So we're going to start out with the first article on the ROHI index, the rotator cuff healing index. This is a single surgeon study over 10 years, minimum follow-up of 1 year, remarkably 603 patients with an average follow-up of 34 months. So pretty impressive total number. Mean age was 60. Overall, their healing failure rate, as defined by either MRI or CT, was at least 1 year from surgery, was 24%. And this enabled them to do a really comprehensive multivariate analysis, looking at factors such as that had an impact, such as age greater than 70, AP tear size of the, or AP size of the tear, extent of retraction, infraspace, fatty infiltration, bone mineral density, and high level of work activity, all as being important factors. And then they sort of graded it based off the impact and based off the overall odds ratios associated with each one. So a score of 4 for retraction, 3 fatty infiltration, the infrastinatus, 2 the AP tear size, the bone mineral density, the age, and the work activity. And when you sort of add all that together, a score of less than 4 had a 6% failure rate, greater than 5 had a 55% failure rate, and greater than 10 had an 86% failure rate. And then there's some more details on specific failure rates depending on your actual score. So it's a really interesting decade-long study, great analysis, really dealing with MRI or CT healing. Kind of helps start to better elucidate somewhat of a definition of repairable versus irreparable, and a great foundation for future studies. So we felt that this was an appropriate way to sort of kick off this failed cuff, because naturally these are a lot of the factors that are associated with these failures that we see, and then we have to sort of deal with what's the next phase in this. So maybe I'm going to kick it off with you, Grant. So do you want to maybe expand upon my summary of this article, in that what do you consider are important factors when you're predicting or evaluating if you need to augment something for let's say in this case a primary rotator cuff?
Yeah, thanks, Eric. Thanks, Chris, and thanks to Smith & Nephew for putting this on. It's an honor to be here. I think that this is the article we've been wanting for a long time, right? In many ways, right? We've been saying, we have these clinical questions of patient looks at you, hey, is this going to work? Is this not going to work? And especially now as we have, the reverse is an option, tendon transfer, balloons, et cetera, the question of, are we going to go through the complex and lengthy rehab of a rotator cuff is more germane than ever. So it's really nice to have something like this. I do think this is not the be all and end all. But I think it's an incredibly well done work, and the group at in Korea should be supported for that, or should be lauded for this. I think for me, the biggest factor for me is smoking, actually, nicotine use. So in our clinic, you've seen it, right? The patients come in, they've got the folder with the outside records dictating all the failed surgeries, and the records themselves smell like smoke, and they're wondering why their surgeries aren't working. And it's like, this is probably part of the picture. So for me, that's it. There's some older data from Mattson and Harriman showing that at every rotator cuff repair or tear size, the failure rate is doubled if the patient is smoking. Now, and if you look at massive cuff tears, they have, 40%, 50%, 60% failure rate. So if you double that, you're 100% failure rate. So for me, the smoking is really the big one. The question for that is like, well, how long do they have to stop? Is it something they can wash out? So for me, that's a big one. I'm still getting my head around some of the bone mineral density and some of the stuff in the Rohe score, right? I don't routinely check that on my patients. So listen, I think this is helpful, but I think there's, for me, like the work activity is something that I have to think about a little bit more. I don't have a lot of patients in their late 60s and 70s with like a high variety of work activity. But anyway, I think that's my big one for me is smoking. I think the other big one, and like, this has been put on the map, is the high cholesterol thing is a big one. We see these patients, young people come in, they've had some heart issues. That's another one that gets under-recognized. But anyway, those are my thoughts. I see Dr. McDonald's hand up.
Yeah, Grant, those are great thoughts. Just to extend that a little bit further, I know smoking is a huge factor, but do you operate on smokers, or do you tell them to go away, quit smoking, and then come back when they've quit? And further to that, do you check nicotine levels to verify that they've quit?
Yeah, good question. I operate on smokers. I don't verify them. I just tell them the facts. I say, listen, this is a clear and present danger. I know it's a stressful time, but your risk is doubled and you should stop now. Like, don't have another cigarette after you leave here. And if they do smoke, or if they do quit, they quit. If they don't, they don't. Now that's for something where it's time sensitive, an acute tear, a fracture, that sort of thing. If it's a chronic cuff tear or revision cuff tear, like I just said, if it's a revision massive cuff and a smoker, I'll tell them I'm not doing your surgery unless you stop smoking. Now, I don't go so far as to check the levels, but I think that's just a total waste of time if they're still smoking. And they have to meet you halfway, right? I mean, if they've already failed a big surgery and they're not willing to stop, then I think they got to bring something to the table.
I think we have to, I love this study. I think it's a huge amount of work that went into this, and really, great data that's very useful. But I think we have to be a little bit careful how we interpret the data, and not to overinterpret it, because it's important, I think, to remember that they didn't correlate healing with the functional outcomes. And most big studies that look at rotator cuff healing don't correlate in a large population healing with outcome. And so for me, this study really tells me, kind of separates out two groups of patients. It lets me know, which patient isn't going to heal. And for me, that means that there's a patient who may not heal, who I think healing is important for that person. So that would be based on other studies, like the younger person, the more active person, the work demand person. So if I identify risk factors for that patient who I know should heal their rotator cuff in order to have a good outcome, then I may augment those people preemptively. On the other hand, it tells me that there are some older patients who I can predict may not heal. And for them, it also seems like healing is less important. And so I'll be less aggressive with them in terms of what I do surgically. And maybe for those people, it's enough to do a Mattson smooth and move, a debridement, something with a less extensive rehab, if they already have an incredibly large high risk of not healing, but they're an older person that doesn't have some of those risk factors that make you think that they're going to have a poor outcome with a failed repair. So I think we just have to be a little bit careful not to overinterpret this like we either shouldn't operate on some patients who have poor healing potential. It just may alter the type of surgery you do, because conceivably all these patients were indicated for surgery based on failure of non-surgical treatment.
Yes, so Serena, then how do you incorporate that? Are you changing what you're doing for these patients? You mentioned the smooth move. Are you augmenting? Are you like, how are you incorporating your this and other similar kind of studies to your sort of algorithmic approach on these patients?
Yeah, so like for me, if I have an older patient who meets a lot of these criteria, let's say they have a 70% chance that they're not going to heal their repair. They're an older patient who has good range of motion, whose main problem is pain, then I won't put them through an extensive cuff rehab. I'll talk to them about a debridement, something easy to biceps tenodesis, tenotomy as described by Bolo and Walsh, something low cost. I'm not a big ballooner, but if you're a balloon advocate, then that might be something that you might consider for that patient. If there's somebody who's older that has poor healing potential and no function, they have shoulder shrug elevation, and it's a 70% likelihood they won't heal, then I'll have a conversation about a reverse in that patient. And if they're a young patient who I think healing is important for them because of their other demands, and they have a lot of risk factors, then I'll augment that person with either a dermal graft or some sort of cell-based augment.
Awesome. How about you? So for when you're deciding between you're trying a primary repair versus maybe you're going to something like a tendon transfer versus a reverse. Talk to us about like what you feel are the most important. What are the main things that are pushing you? As many know, you don't make intraoperative decisions. You tend to make preoperative decisions. So talk to us about your preoperative decision making in these patients.
Yeah. So I think there's another article about it because I do the tendon transfer for augmentation as well. So my method of augmentation is tendon transfer. So this article is great. And yes, it has a lot of things we read about. Like in this article, when I'm looking at the grading, retraction, fatty infiltration of the infraspinatus, which I think is very important. But then you have to talk about the AP size, age, BMD, and work activity. For example, like the bone density, some of the patients, you cannot put an anchor in the bone. You can have a great tendon. You try to repair them, you cannot repair them. The other thing is the quality of the tendon. This is something I feel is the future to know, because many times you see surgeon looking at the tendon, it looks okay, this one I can repair it. And then you go in and I see one after one coming, they fail within the muscle tendons because they try to pull on the tissues, which is not good. And the third, other than the retraction, the length of the tendon, which for me is extremely important. So all of this factor will take them into consideration in terms of what we should define as reparability, because this is also important. We keep on talking about sometimes when we define pseudoparalysis or pseudoparesis because we want to define what's the difference between the two. When I ask this faculty, I give you MRI, is this reparable or is it irreparable? Do you mean during surgery I can pull it and repair it? Or do you mean I can repair it's gonna fail later? This is something also we have to talk about because many times you'll be able to fix the tendon, but the tendon may not heal. But anyway, for me, number one is the length of the tendon. This is for me number one, because if the tendon is really short, for me, this is the work by Dominic Meyer. It showed is if the tendon, let's say the supraspinatus is less than 1 centimeter, this is worse than Goutallier grade 3 and 4. So some of these we don't talk about them. We talk about retraction, the length of the tendon, and everyone spoke about something. Now, one more thing, just for the fun of the discussion about the smoking. I was with Christophe Oberlin, like Oberlin transfer. I was with Christophe Oberlin in France. And there was a patient coming, he has a bad fracture of the humerus knee, the fixation, but it looks like heading toward non-union. It has been 4 or 5 weeks. And I said so mon ami, the Mayo Clinic, I was at the Mayo Clinic. He told me, what would you do for this one? I told him, he's a heavy smoker. I think we should stop smoking first. He looked at me and he laughed. He said, if you're gonna not do surgery for someone in France because they smoke, you will not operate on any patient. So this is for fun of it, because I do not mind at all operating on smokers. This is for the fun of it. Thank you.
Maybe that's why they do so many reverses there.
That's
maybe. He doesn't love a good dart, Hey, Serena, you did a lot of great work on work status and cuff healing. Can you just comment on that, because it's really great stuff that you've done?
Yeah, I mean, I think we've shown that that if you're a work comp patient or a manual laborer, your cuff healing is important. So if you take a group of patients who have unhealed cuffs and you look at their outcomes, the group that does the worst are the ones that have high demand jobs or are work comp. Doing a revision rotator cuff repair in a work comp patient is like flipping a coin, whether they actually will get back to their usual work. So I actually think, their work demands are very important. One comment on what Bassem said, I think the tendon length is super important. The one thing that I think can fool, that has fooled me before, and I think can fool others, is the tear pattern. Like sometimes you see these L-shaped tears where if you measure the tendon length on a coronal MRI, it's very short. But when you get in there, you pull it A to P and it reduces very nicely. So some of these tears that look like they have a short tendon are really not that short of a tendon and can be repairable. So his point about whether you can repair it or not is great because you really can't predict that very well on your MRI.
Wonderful. Pete, you had a question?
Yeah, I think all these things are really good points. I think this article helps us, but it's not, as Serena said, it's not the be all and end all. There's a lot of factors. There's smoking, there's WCB, there's tendon length. There's things that are outside this article that we've heard about that are important that aren't part of the scoring. So I think that this helps, but it's not the be all and end all.
Wonderful. Chris, you want to go on to the next one? I agree.
Yeah, absolutely. And, special thanks to Pete for joining us today. He's attended every single journal club we've ever had, so we had to have him as an honorary member today. So Pete, thanks for joining us. All right. So the next one we're going to talk about is the bioinductive implant paper. And the title of the paper was An Isolated Bioinductive Repair versus Suture Repair for Full Thickness Rotator Cuff Tears, 2-year results of a double-blinded randomized controlled trial. So the authors of the study state that partial thickness rotator cuff repairs treated with bioinductive implant have shown success. They concluded that this is because of the remaining structural integrity. They wanted to investigate if these principles applied to full thickness rotator cuff tears with rotator cuff table remaining intact changed the prognosis. They designed a prospective double-blind single-center randomized controlled trial of patients greater than 18 years with small to medium-sized tears defined as less than 2.5 centimeters full thickness supraspinatus tears and an intact rotator cable. Patients were randomized to arthroscopic transosseous equivalent repairs or bioinductive repairs. They had biopsies at 6 months and MRIs at 6, 12, and 24 months along with PROs at all these time points. Demographic, tear size, surgical characteristics were comparable between the two groups. All patients in the bioinductive group had highly organized parallel bundles of collagen without inflammation, whereas poorly organized non-parallel collagen fibers were present in 80% of control patients, with the majority having minimal to mild inflammation. There was an increase in tendon thickness in bioinductive groups compared to a control group or on the MRI. They concluded that the bioinductive group had a 100% healing rate, higher PROs, and quicker return to work. So maybe we could start with you, Grant. Before we get into the weeds of should we do this for full thickness rotator cuff tears, what's your indication for using bioinductive implants at this point?
So for me, and I may be an outlier, but I like something with a little structure as well as biology. And it's, when you look at these different, rotator cuff augments, right? I mean, some are going to be purely structural. That's like your synthetic patches, right? Some are going to be purely biologic. That's going to be like your PRP or your BMAC, right? And some are going to be kind of a combination and somewhere in the middle, So for me, these bioinductive ones, I think are, I would say, a little more on the biologic and a little less on the structural, maybe not quite as far on the spectrum as like a BMAC or PRP. But this is a really, I have not used this type of implant in some time, but this is really compelling. I mean, the fact that they even have the biopsy results, that's incredible. So, this is a paper to definitely sit up and take notice. When you have 6-month biopsy results showing highly organized collagen, statistically different in the groups, and most importantly, without inflammation. I know that was one of the concerns is, hey, it's bovine collagen. Is it going to lead to inflammation? There's some kind of data pro and con of that. And they're not, when you're looking at the pathology, that is the gold standard. So listen, not a huge part of my armamentarium currently, but I am really excited to hear what people say about this paper, because this definitely is a sit up and take notice kind of paper about this product and this and the strategy.
Grant, so you have published and you have used the like a biphasic scaffold that's designed for the enthesis, as well as some work with the dermal allograft. Do you want to talk about you know, the in your mind, the differences between this type of bioinductive, one that's maybe more targeted for the enthesis, and one that's maybe more targeted for the tendon, and how you kind of make that decision?
Yeah, I guess if you would think, yeah. So the grafts I use a lot of dermal grafts on top of the tendon. I feel like they give you some structural support, and they also allow, you know, biology, the kind of the wicking effect, the collagen architecture that's there is helpful. And then under the tension, under the tendon, you know, I think the where the rubber meets the road, so to speak, is where that tendon is attached to the bone, and that's the delicate architecture of the enthesis. And there's a product that I've been involved on. I don't want to make this too corporate, but basically we take it's a piece of partially demineralized bone. So you have kind of bone that sits against the bony surface, and then the demineralized bone kind of acts like Sharpie's fibers is the idea. So it has kind of a wicking effect. And there's some other ones on the market that have a similar kind of wick concept to bring bone marrow elements and allow them to egress in the repair site. So yeah, I guess that would be another type of bioinductive implant that I do use. And I do think that makes a lot of sense to me. You know, again, I know for this device, they've talked about even putting it on the top has shown, you know, peeling of articular sided cuff tears, even putting the implant on the bursal side. And my mind just explodes every time I see that paper. But again, they've got the imaging, they've got the data to support it. So I'm still trying to wrap my head around exactly how this works. I've been kind of more of a put a dermis on the top or put something to bring biology, either whether it's injecting BMAC, whether it's using like the Sparta product, or whether it's using something in the enthesis. So those are kind of the two strategies I've used. But again, I don't want to filibuster. I want to hear what everyone that actually uses this patch says.
It's certainly, so I'm going to sort of direct it towards you. You know, a couple of years ago, you published an article that I often will quote on dermal allograft, and you know, you had obviously a complex patient population and pretty honest paper on failure rates, but really using, or at least pointing to fatty infiltration as one of the primary causes of some of those failure rates, but clearly also some nice successes in those that didn't re-tear. So you want to talk about, since that paper, since that study, how your algorithmic approach to augmenting cuff repairs has evolved?
Yeah, so, you know, in our study, we looked at revision repairs and complex primary cases, so big tears with early atrophy. And, you know, our re-tear rate was 50% using an augment, dermal augment on top, like Grant described. And if, you know, you compare our data, these were all 2 tendon tears. And so if you compare our data to Jay Keener's data from revision cuff repairs, where his 2 tendon tears had a 70% failure rate, ours had a 50% failure rate. So potentially, you know, you improve the healing rate by somewhere around 20% by augmenting. And I think that passes the sniff test. It's pretty reasonable and what you can argue whether that has value or is cost effective or not. So for me currently, I pretty much augment only my revisions with dermis. I have no experience with this implant. I have not used it at all. But I mean, like Grant said, this study is incredible. I mean, it's just so well done. If you designed a study, I mean, you design it this way. But I mean, it's almost magic. This is cuff magic. I mean, the fact that you can put this, and I've used this in a lab, you can put this thin implant on top of a full thickness tear and achieve 100% healing rate is magic, and get the patient moving right away is really incredible. It's almost, you know, and I don't want to say anything negative with our sponsor, Smith & Nephew, because I may not get invited back, but it's almost too good. Like the results are almost too good. And I'm sure they're very honest, great results, but it makes it hard for someone who does not use this implant and doesn't see those results clinically themselves to incorporate it when you have a study that's industry funded, author conflicted. And so for me personally, as great as this is, and I hope this is real, because then you can avoid all of the issues that we have with treating cuffs. As much as I hope this is real, for me, I want to see this validated by another group. Not necessarily, I don't think anybody's going to publish anything this high quality or this well designed, but something else that shows that you can actually do this without repairing the tendon would be incredible to see.
Yeah, you just been uninvited permanently, Serena. It's been fun having you here. Awesome. What do you think? Like, so they moved all their rotator cuff repairs at 2 weeks in the repair group. Can you just comment on that? Are we going too slow with cuff repairs?
So
Well,
I think if you look at and I'll quote Jay Keener again, but he did a nice randomized controlled trial looking at small and medium-sized cuff tears, moving them early versus late. Both groups had really high healing rates, and both groups had equivalent healing rates. So I think these were all small to medium-sized tears. So I think you can make a very strong argument to move them early. And I do move them early. So, I don't think there's anything wrong with that. The larger tears are the ones that there's data that supports higher re-tear rate if you move them early.
Hey, Pete, do you have a question?
no, I'm good. I'm good.
Yeah, I mean, I'm just not trying to be nitpicky here, but it is an industry-funded study, and also it's fairly small, so potential for being underpowered. So it'd be nice to see this repeated. I do think this product works. I do think it's a great product. I do think it enhances the ability of cuff to heal, but I think that we need kind of to build on this and to have bigger randomized clinical trials.
Hey, awesome. So you mentioned you use 10 transfers as your augment for cuff repairs. Is there a role for this bioinductive type of patch in your role? Is there a role for some of the other structural grafts and or in the revision setting? Is there something that let's say you have good muscle that you're considering?
Unfortunately, well, maybe fortunately, unfortunately, I don't see partial rotator cuff tear in my practice. I hope I can see. I'm not kidding. I don't see them, but I would say I would do this 100% if I have a partial tear patient, not this specific product, but I have a product that I trust. This is what I would do. I will patch it. I will not repair it. This is what I would do. The only tricky thing for me about this paper, and I'm not sure if because this is only like the preview of it, I think it got accepted. I don't see pictures. I don't see pathology pictures. I don't see any of the stuff. Where are they? Because I like to see them, number one. Number two, this study would have been perfect if they added one group, which is debridement only. Why? When I do the lower trap, there's a group of patients, if you recall, I did not repair any rotator cuff. And some of them, when we went back for biceps, the capsule was sealed. Everything was sealed. I wonder what would have happened if we took a biopsy from these tissues, what would it have shown? So it looks, as Serena talked about, it looks like a little bit of magic. But even when you talk about the cable, like if Patrick Denard published about the paper where essentially he's not even repairing the middle part anymore, and essentially he connected the rotator cable, and that's it, and he showed very good outcome. So it will be good to have follow up with people, not biased, independent, interested to use the product to see if this is really how real this is.
Does anybody use any other biologics like PRP, BMAC, that type of stuff when they're doing revision cuff repairs?
I do. I'll use PRP in revisions. I tell patients I don't know if it will help, but I don't think it will hurt. And it's kind of bundled into the surgical cost, so they don't see a personal extra cost to it, which I have a problem kind of using that as a way to increase the cost of the surgery for the patient. So, just because I don't know if it'll work, but I do use it in revision repairs.
Can I ask a question for the faculty? Since very quick, if you had a partial rotator cuff tear, what would you have done on yourself?
Rehab.
That's my answer. Anyone will have a patch in your shoulder to patch a partial rotator cuff tear?
Well, I think you try rehab first, try non-operative, but if it doesn't work, then I wouldn't hesitate to have a patch.
Yeah, I would rehab. I will not let anyone put patch on my shoulder. But anyway.
No, I mean, I agree with Peter. Like, I think we're all assuming that these people that have gone to this have failed extensive rehab, but no, I mean, why? So to your earlier question, Eric, I use BMAC, so bone marrow aspirate concentrate, in not all my patients, but revisions for sure. My colleagues before I got to Rush did a prospective randomized trial and showed some improved healing rates. There was a blinded trial when they were putting BMAC in an MRI follow-up. So, it was a small difference, but a statistically significant difference. So I think that, there's some data to help to show that might kind of tilt the odds a little more in your favor, certainly in these ones where it's a larger tear or redo.
Yeah, oh, that makes sense. Perfect. All right, well, let's in the interest of time, let's keep going, and this probably will produce some similar, hopefully, similar discussion along what we were just kind of getting at to. So this is a different type of, we're going to talk about the biceps tendon augmentation versus partial repair paper. So a different type of quote unquote biologic augmentation. So it's a single center retrospective comparison study over 5 years, partial repair versus the biceps tendon augmentation. If you look at the way that they did the augmentation, a little bit different than the biceps SCR that you hear talking about. This is where you incorporate around the actual insertion of the repair. Their indication for this was irreparability, dealing with either retraction, pate stages, or pate infiltration, or some combination of those. There's 60 patients total, 30 in each group, so 30 partial repairs versus 30 partial repairs plus this biceps augmentation. Looking at the biceps did have a younger age, potentially biases things, otherwise relatively similar. And if you look at it, the retear rate for the partial repair with biceps was only 44% compared to 73% with the partial repair alone as assessed by an MRI. So when you looked at the passion for outcome measures, really constant Morley was the only one that was different. All the other ones were very similar. However, the Sugaya and the AHI were better for the one that had the bicep. So it's an interesting study talking about a different type of augmentation, sort of almost like a quote unquote free augmentation that's shows the biceps. I know there's been a lot of attention on biceps SCR or some biceps cable reconstructions and all kinds of different versions of this. But this is sort of another kind of interesting, very well done MRI and clinical comparison. And then kind of a nice foundation as we talk more and more about the biceps, is there's been a huge regeneration in the last, 5 years talking about using the biceps. So Bassem, I'm gonna start with you. When do you use the biceps in either cuff or tendon transfers or augments? And then how are you using the biceps, and sort of how are you interpreting this study in your practice?
Well, I do not know. Like, one of the surgeons is Roman. I'm not sure if you know him. Roman is from Poland. He is a fantastic arthroscopist and surgeon. He trained with Laurent Lafosse. I've seen him operating. He is really a wizard around the shoulder. So when you look, and even if you look at the technique, this looks not as difficult, but still need to pull the biceps, fix it, and use it essentially to augment the lateral aspect of the cuff. You're just adding collagen to the lateral aspect of the cuff. And in fact, I've seen this technique before. I'm not sure this is their original technique, but I've seen it before. My interpretation for it is just because you're augmenting the rotator cuff with more collagen. Like, this is essentially using a fresh autograft. Like, when you talk about the smash technique of the JT Tokish, is like essentially taking smash it, put it on top. This is like keep it in place, but just place it. I think this is why I think it worked better. For me right now, because I usually do biceps tenodesis all the time. So now I tenodesis in situ, like the way just in the groove. I do not rely on it, but just as part of the procedure. But in instances, and this is what I want to ask, because when now we talk about biceps augmentation, it seems like we always use it. But many times the biceps is enlarged, it's shredded a little bit, it's not in good quality. There's a labral tear with it, degenerative labral tear. And I wonder how this will affect also your decision to use it as a typical biceps in situ SCR versus technique like this. I do not use it except in massive tear if it is there, because I'm gonna this either way. So I'll keep it in place and I do the lower trapeze transfer, but I do not use it otherwise in other situations.
Yeah, fascinating. Grant, what about you? How are you? So first off, maybe just mention about this study and kind of your take on it, and two, then your use of the biceps, whether it's in a similar fashion to this in the biceps SCR standpoint, or maybe not as part of your algorithm.
Yeah, I mean, I've seen an evolution in this, right? I mean, when I was sort of a senior resident and fellow and new attending, it was like, oh, the biceps is full of, substance P, pain fibers, huge pain generator, get that thing out of the way. Like, it is just any biceps you see, get rid of it. It just causes so much pain in the shoulder. It has no functional ability to do anything. Remove it. If you leave it, it's like basically malpractice, because you're going to have continued shoulder pain. And now we've evolved to, hey, you can take the biceps, swing it out of its groove, move it over there, have it articulate with like a non, groove part in there. Their pain's fine. So I'm not saying I don't believe either of those two schools of thought, but it's amazing how far this pendulum has shifted, that something that was once the major pain generator in the shoulder is now something we can move, manipulate, and kind of retract with impunity. Now, I will say, I have met Roman. He is an excellent arthroscopist. And I think this makes sense. This one, it's still tenodesis at the top of the groove. So, I think, again, you're just using the collagen. I mean, you could easily just say, hey, I'm going to cut a piece of biceps out and lay it on there, and effectively it'd be the same thing. The one thing, though, with these massive tears, and this is kind of just a takeaway from this for me, is you don't want to get your eye off the ball, right? You want to keep your eye on the ball of, thorough bursectomy, right? Tear pattern recognition, mobilization, footprint preparation, secure repair. Like those paradigm that Steve Burkhart taught us so many years ago, that remains the same. And if you're going to add all these extra things on top there, be they grafts or biceps, you just got to make sure that you're not, giving short shrift to some of those other items. And the reason is, you only have so much time in these cases, right? It's swelling. And so I guess what I'm saying is, you got to make sure that if you're going to do something like this, that you're still making sure you're taking the time to mobilize the tear, repair it, because this is not going to save you from poor technique in those other areas.
Eric, can I ask you what you do?
For a massive tear?
No,
Like
like you, and I was asking Eric as well, because he does a lot of that also. Like,
Eric,
like
yeah,
tendon
go ahead, Eric.
transfers.
Okay, yeah. So don't want to take the focus off y'all. I do like the biceps. I do it as more of an SCR, where I do a tenodesis in the below the groove, and I'll leave it attached to the superior labrum, and then I'll use it to augment either a repair or, as Boston, you and I have talked about, as a tendon transfer. So I do think it's helpful in that respect. I have not used this technique. It's an interesting technique and it makes sense, but I've not used this. Sharina, what about you? You've talked a lot about the augmentation. Even back have some older publications on SCR and some editorials about that. So, what are your thoughts on this? What are your thoughts on this? Free. You mentioned the cost of PRP. Well, this is a free augmentation. What are your thoughts on this versus using it in more of like a SCR or Pat Nard's cable reconstruction?
Yeah, I mean, I like using the biceps. I think I've evolved away from SCR, not because my results were horribly poor from a clinical standpoint, but more because of cost and time and I was looking for something else that might work for that patient population that I thought SCR was best for, which was usually, the patient whose pain was the biggest problem, questionably repairable cuff tear that I was going to try to fix. And if I couldn't fix it, then I had consented them for an SCR. Now, if they have a biceps, I'll typically do a partial repair and then transfer the biceps outside of the groove and bring it over the top of the tuberosity. Now, initially, when I heard Larry Field describe that technique where he does not do any tenodesis of it distally, he just leaves it completely intact and just transfers it out of the groove, I was worried that would lead to stiffness or biceps pain or, all sorts of problems. And so I read his paper, I talked to him, I was a slow adopter of it. But so that is actually what I do now in a lot of these patients. And I've been following them. I've only got about 15 or so, but so far so good. I would say that I'm as happy with that as I have been with SCR or with any of the other kinds of operations that I might do for that indication. And it's like you just said, no cost, and they don't have a Popeye deformity. It seems like it's reasonable. The one comment on this paper I would say is we do have to be a little bit careful with fragility in this study. If you look at the healing rate, it's it's about 30% difference. The p-value is 0.036. So if there was just one or two patients in the opposite group, the results would not be statistically significant. So with Peter mentioned it earlier, but you know, with small numbers, you just have to be a little bit careful seeing this as like it absolutely will improve the healing rate. Because if you just had a few more patients in another group, it would really change the data. But for me currently, I like the biceps. I like using it. I'm still like Grant, I'm still not sure what the right answer is for the biceps, but I have not seen problems with tenodesis, tenotomy, or using it as an augment.
Sure.
We have a question from the audience, and maybe Pete could tackle this. This is from Timothy, who's a PT. He says, "Nice to hear you guys will still try rehab first for rotator cuff injuries." I hope a lot of people do, but that's concerning to hear. What amount of time for PT to work, and what interventions do you typically do that you feel is important, Pete?
Yeah, I think this is an excellent question for therapists and for surgeons as well. You know, up in Canada, of course, even our best efforts take a while to get patients into the OR sometimes, but I'd say in general, 3 months of rehab is appropriate. The exception might be a younger patient with an acute massive tear or pseudoparalysis or something like that, where you want to move to surgery faster. But in general, we try rehab for about 3 months in most tears, especially degenerative tears.
And then we have the, that's interesting, the Canadian perspective. I would say, I mean, we have the Moon group data on full thickness tears. And that data for full thickness showed that if it was going to work, they typically saw improvement within 6 weeks. So I have used that with my patients where there's a full thickness tear. Not so much to say, hey, we'll only try 6 weeks, but try at least 6 weeks, because you'll know then if it's going to work or not. And because patients are worried that you're going to send them to therapy forever. And if you tell them, hey, we're going to do 6 weeks and we'll see how it goes. And if it's going to work, we'll know. So I like that 3-month idea, but I can usually get patients to at least agree to 6 weeks. After that, someone's a little harder to talk them into it.
Yeah, perfect. That's awesome. So I mean, I guess we can just sort of leave this augmentation and maybe go to another one before we go on to the subscap. So any revision setting with maybe stage 2 fatty infiltration, but all in all intraoperatively repairable rotator cuff, can maybe each of you say what is your favorite way to augment that? Meaning they have enough tendon that you can get back, but clearly it's a revision setting, so it's not going to be native tendon. It's, let's just say, 55-year-old. There's grade 2 fat infiltration in the supraspinatus and infraspinatus. So not over the bearing, but definitely not complete native. And they've had 1 failed rotator cuff repair, non-smoker. What's your favorite augment that you do for this patient? So Sren, you want to start us off?
Yeah. So that patient, usually like you described, you can get the tear back to kind of the medial footprint, but it doesn't cover the entire footprint.
Yeah.
So for me, I'll put anchors medially to repair the tear to the medial footprint without trying to overtension it. And then I'll put a dermal graft on top that bridges over the top of the tuberosity. And the sutures that are going through the cuff, the native cuff, are the same sutures that are going through the graft and tied, in order to really augment that suture line, as opposed to just placing a graft separately on top of it. I want the graft between the knot and the tendon. So that's my current algorithm. And then at the end of the case, I'll put a spinal needle in through the graft and drain the fluid and inject some PRP and pray.
Love it. Grant, what about you?
Yeah, similar. So I'll try to, I'll medialize, you can medialize the footprint a little bit, can be helpful to get a little more coverage. And then if I can't get the full footprint covered with a reasonable degree of tension, that's a really good one for me for some dermis allograft, and then BMAC as well. The time where I'll use like something with just the enthesis would be if it's a smaller tear where I can get full compression, but I'm just really worried about healing. So that would be your smokers, your diabetics, your revisions. That's one where you could consider like one of those, like the Sparta product or just a BMAC or something underneath to try to improve the biology. But this one where you want increased footprint increased footprint coverage, I think that's a great indication for something over the top, like a dermal graft.
Awesome.
So if I have any worry that this one, again, this is where we talk about, is this reparable? By reparable mean you can put it on the medial side, will it heal or not heal? This is what I talked about it early on. So if this reparable, it means you can fix it, it's gonna heal or it's not gonna heal. So if I have any doubt about it, I will do lower trap for it.
Awesome.
You repair it and then use your lower trap as an augment.
Yes.
We have a deep thinking question here. So I'm going to ask you, the patients, this is a question from the audience, patients who need an SCR for irreparable tears versus group of patients with biceps for SCRs that just need augmentation that are repairable. Are they mutually exclusive or are the same type of procedure?
So irreparable tear SCR versus reparable tear with biceps?
With augmentation.
With
do you
biceps
treat them the
SCR. So
same?
biceps SCR for reparable, regular SCR for irreparable. Are they mutually
I don't think they're the same at all, because if you'll be able to repair the anterior, like the posterior superior rotator cuff and augment it with the biceps, we're talking only about the biceps. The both groups are reparable, one with the biceps, one with SCR. Well, right now, like not from me, of course, multiple studies like Pat Dinosh has showed and other has showed in meeting, they're trying essentially, this is why some of the surgeons that have been a big SCR proponent, they're not doing it anymore because they're showing the biceps is the same result. In fact, Sorena just mentioned it right now. He said he used to do SCR not because he did not have good outcome, but because the complexity is less. They're having very good outcome. This is biologic. I think for now, yes, it sounds like as long as you don't have ER lag and you don't need tendon transfer, if you want to compare SCR to biceps SCR from multiple people who are proponent now of both and doing both, the biceps seems it is working as good as the SCR. Sorena, you agree?
Yeah, I mean, I think if you have a reparable tear, an SCR is not indicated, to answer part of that question. If you have an irreparable tear, then I think you can make an argument for SCR or for biceps augmentation with, some sort of partial repair. I think it's very rare to have a completely irreparable tear where there's no part of the infraspinatus or upper border subscap that you can get attached. That's very unusual for me. So because of that, for me, usually these tears are partially reparable, and the same patient population would be amenable in my hands to either SCR or biceps if they have a biceps. But for me now, in that patient, I've gone to the biceps.
Yeah, I wonder if any of the panelists are still doing SCRs in any situation, because I think most of us have moved away from it, but is there any indication to do an SCR anymore? Any of the panelists?
Yeah, I'll feel that. So I've actually looked at this literature, and I think the SCR, it's funny, I was not an early adopter of the SCR. I thought it was way over pushed and overhyped by industry. I still feel that way. And then I feel like the pendulum swung back, where I think now people are overly negative on it. I don't think it's the perfect operation. If you look at the literature, it has about a 70 to 80% success rate. That's across many studies over a number of years, including Pat's own studies. That's not a great operation. But we have a large workers' comp population. So if you have like a laborer, 50, laying bricks, doing cement, climbing, utility poles, massive tear, certainly you could consider a tendon transfer or one of these other options we've considered. But I will say that the data on SCR, if you look at it, is as good or bad, depending on if you're glass half full or glass empty, as anything else out there. Now you can argue the cost argument and all that, but Mahada's got now 10-year data. So this original idea that it was, it's not working because it's just a soft tissue spacer and it's only going to pad things, and the only reason they look good early is, well, that doesn't make any sense, because first of all, we now have the balloon that people are using. Well, that's clearly a soft tissue spacer, and people seem very comfortable with that concept. Number one. Number two, the way Mahada does it, which is different than how we do it here in the United States typically, but they've got 10-year data with great results. So again, people are probably virtually throwing tomatoes at me here, but I just think that it got kind of too much hype early, and I think it's gotten too much of a bad rap of late. I think it still has a role for me. Massive irreparable tear of the supraspinatus. Infraspinatus is intact or reparable. Subscap intact. in a laborer with no arthritis, I think it's my ideal operation for that patient.
Yeah, and I should clarify. I mean, for me, I haven't completely abandoned it. It's just my utilization is incredibly low now. If they don't have a biceps and it meets all of the other criteria that Grant talked about, then I'll still do an SCR. I've changed my technique. I mean, based on the thickness data published by Ty Lee on the graft, the fact that we use allograft, not autograft. I double the graft. I suture it on top of itself, so it's about 7 millimeters. And I'll still do it. It's very rare though. I mean, I went from a situation where I was probably doing 10 to 15 a year to 1 or 2 a year. So I think that's been my attrition, to be fair.
So I just want to add one quick thing. In the whole Massachusetts area, the reps of the company were telling me we do not hear it anymore in the whole Massachusetts area. After it has been, oh, we used to do like at least one per week or whatever. We haven't done one for almost a year. Anyway.
Awesome. We've got one more quick question before we move on to the next article, and maybe Pete, you could answer this. This is from Mike Gottschalk. So why do you think the results of the SCR are not reproducible? Do you think it's because of indications?
I think with SCR, it's a technically demanding procedure. There's been shown in some studies, including the one out of JP Warner, Jarrett Woodmass, that if you've done less than 10 SCRs, you can expect a 60% failure rate. So you really need to master this operation before you go to the bank with it. And that's one of the reasons I think there's a good excuse to move away from it, because it is so technically demanding, so expensive. So I think that the reason for SCRs not working in some groups versus other is some people have technically mastered it and some others have not. Plus the indications, of course, the indications have to be appropriate.
Okay, awesome. Thank you. Okay, so let's move on to the subscap healing in our last 8 minutes or so. The purpose of the study was to identify the prognostic factors for subscapularis healing after arthroscopic rotator cuff repairs. This is a case-controlled retrospective review, prospectively collecting data from a single institution. All patients had 2-year follow-up. Subscapularis healing was evaluated on ultrasound, had final follow-up, and PROs were collected. The overall re-tear rate was 10.8%. Risk factors for healing include female sex, body mass index, supraspinatus fatty infiltration, lower subscap fatty infiltration, and LaFosse classification 3. They developed a 15-point scoring system, which comprised of the following: 3 points for female sex, 2 points for BMI over 30, 3 points for supraspinatus fatty infiltration greater than 3, lower subscap infiltration, and 4 points for, that was for 4 points, and 3 points for LaFosse classification 3. Patients with less than 4 points had less than a 4% re-tear rate, while those with 9 points had 55% healing failure. So those with a healed subscap outperformed those in the re-tear group in all metrics. And they conclude that the subscap healing index scoring system integrates clinical and radiographic factors, predict subscap healing after surgical repair. So successful subscap healing was found to be associated with enhanced functional outcomes, underscoring the clinical relevance of subscap healing. So, boss, I mean, what are your techniques for maybe some of the fellows and more junior members to how to get good subscap healing?
Well, it depends if it's small tear or a big tear. I usually go intra-articular for the proximal part of the subscap, and usually almost always requires only one anchor, especially if it's small tear. And I always go extra-articular for the larger tear. Honestly, I learned it mostly from Laurent Lafosse, because I know it could be technically demanding. I know the fellows, this is what they try to learn during their fellowship, and then even after they master it. But the mobilization of the subscap is extremely important. Like when you have a retracted tear of the subscap, the way you essentially place a suture or grasp the subscap and try to do circumferential release to have a good mobilization is important. And I almost always do double row technique. And for larger tear, almost always at least 3 anchors medial and 3 anchors lateral. This is what I would do.
That's awesome. So from y'all's standpoint, comparing a subscap versus maybe a posterior superior that we've been spending most of the time talking about, what are some fundamental differences with regards to how you approach it from a healing standpoint, from a need for augmentation standpoint. So, Serena, do you maybe want to take this, like, different muscle, obviously different muscle belly, obviously different forces. What are the main differences you're considering? How are you approaching this differently in posterior superior? Are you using the same sort of algorithms or changing it up?
Yeah, I mean, I think just a couple of comments for maybe some of the residents and fellows. I mean, I think subscap, a full subscap tear is usually traumatic as opposed to posterior superior cuff tears, which are generally atraumatic. So I think there's an important distinction there. They tend to retract and atrophy more when they're full. So they're a little bit more time sensitive for me as opposed to the posterior superior tear. And, I think augmentation of a subscap can be much more tricky. So, even though I feel like I'm pretty comfortable augmenting a posterior superior cuff tear efficiently, I think that technically it's harder to do that in the front of the shoulder with a subscap. So for me, I actually, in cases where I see some of the signs that they're talking about, where their tear may not be healable or even repairable, sometimes you see those borderline subscaps that are all the way kind of retracted to the coracoid, and they have some early atrophy, and I may be thinking about an augment in those cases. Those are the ones that I'm more likely to actually do open. I'll plan to either augment with a graft in an open fashion, or to do a lat transfer as an augment to whatever subscap I can repair. Because I mean, my results of isolated lat transfer, Bossam's results I'm sure are much better, but they're 50-50 when I can't repair any of the subscap, but they're much better if I can get any portion of the subscap repaired and I use the lat more as its own augment, then my results have actually been pretty good.
Grant, so from your perspective on the subscap, and obviously there's sort of a lot of considerations that beyond what was mentioned in here, but are you what is your approach to the retracted, maybe certain aspect of fat infiltration or questionable tendon quality? What's your approach to that patient? How are you enhancing the healing?
So a couple of things. One is, exactly as Serena said, it's a different animal a little bit than the posterior superior tears. I mean, the subscap is the largest rotator cuff muscle, right? And the tendon is very thick. Certainly the upper old board is very thick. So for me, I feel like the mechanical augmentation is often not as much of an issue there. Now, sometimes I may need length. I may have a hard time getting that over. But I feel like it's not like that. You don't often have that wispy tendon quite to the same degree you have in these posterior superior tears. You have a healing problem, a tension problem, or a traction problem, but not necessarily like a wispy tissue problem. So I think that's helpful. I think, lest Peter McDonald think I'm some kind of profligate spender because I still do SCR, I actually really like open cuff for isolated subscap. I think, all the things we like arthroscopic cuff for, improve visualization, don't have to cut the deltoid, all that stuff. When you're doing a little tiny deltopectoral approach and you can get right down. So if it's isolated subscap, I would have a very low threshold for just doing an open cuff repair. Why is that important? Because even if it's a big one, and Serena said, these will often retract quickly. You can get in there, you can palpate the axillary nerve, you can do very aggressive releases very safely in an open fashion. Certainly they can be done arthroscopically. When I do them arthroscopically in the setting of a posterior superior, concomitant cuff tear, I do them exactly as Bossam said. I learned the same thing from LaFosse. But if it's just a massive subscap tear, that person that gets their arm wrenched back, go delto pack, feel the nerve, do your big releases, you can get it over. And I have found that I typically don't need an augment with those acute or subacute tears, no matter how big they are.
So can I add one more quick thing for the fellows here? And this is principle, when we talk about anterior and posterior rotator cuff, the rotator cuffs, all of the rotator cuff are posterior. They're not, the anterior and posterior is with respect to the scapula. And I know you know me, I talk about the scapula. About the subscap is the only rotator cuff muscle that's hugging the chest and all the critical structures going around, because you have, like, even the throat 3-dimensional, You have like the brachial plexus come close to it. This is why I feel what both Grant and Serena mentioned, like you have a low threshold to want to make it open because you're more comfortable, you'll be able to see better. Absolutely, to be able to mobilize very well, to have it to get repair. And what Serena talked about augmentation, absolutely. If I have any doubt with everything spoken about in this article and others, I will always augment with latissimus transfer.
Wonderful. Amazing. Well, thank you all very much. We're going to wrap up so we can stay on time and get y'all going with the rest of your evenings. But really appreciate Serena, Grant, Boston. This is phenomenal. Pete, amazing guest appearance. Thank you for being probably the only one who's tuned into every one of these that we've been doing over the past 4+ years. So thank you all very much, and have a wonderful rest of your summer.
Thanks, guys. Great job.
Good night, everyone.
Thanks, guys.
Thank you.